Give it 1 second.
I'm waiting for the red. Good afternoon, and welcome to the session on vertical healthcare consolidation on the rise, what's a state to do. My name is Jane Beyer, and I am the Senior Health Policy Advisor for Insurance Commissioner Mike Kreidler out here in Washington State, where it's still morning. And so for some of you, good morning, for some, good afternoon. And I have just some housekeeping things to let you know that the PDFs of the presentations that we are going to be going through today are available on the mobile app, and the recordings of the sessions will be added and available soon after the event. As always, whether a NASHB conference is live or virtual, please help us by filling out the session evaluations. We really do use those in planning future conferences. And we invite attendees to use the Q&A feature to submit questions to us. Michael and Aaron and Vicki and I will try to talk fast so that we have time at the end of the presentation or the discussion to answer questions. So with that, I will let you know we have tried in designing this session to make it more of a discussion or a conversational session. And so you'll see different faces popping up as each of us are talking. We hope that's not distracting to you, but we really did want to try to make this more of a conversation about a very, very important and topical issue. And so our panelists today are Erin Fusé-Brown, who is an associate professor at Georgia State University College of Law. And she also is a wonderful NASHB consultant who has been working with NASHB on any number of important issues. We really appreciate that. And Victoria Veltri, who is the executive director of the Connecticut Office of Health Strategy, and Michael McKenzie, who is the deputy chief of the Antitrust Division in the Office of the Attorney General in Massachusetts. So we are going to start this discussion with Erin Fusé-Brown reviewing a recent policy paper that literally has just been posted on the NASHB website related to vertical consolidation in healthcare. So Erin, I will hand it off to you.
Thanks, Jane, and thanks for everyone for being here and to NASHB for putting on this event. So yes, as Jane mentioned, I recently developed a policy paper for NASHB on the topic of vertical consolidation in healthcare. And a lot of the policy specifics that we're talking about today in this session are drawn out in a lot more detail in the policy paper. So I would just, refer to you there for examples and for some citations and other things that might help you if you're thinking through any one of these issues. So just to define our terms, what I mean by vertical healthcare consolidation is the acquisition of physician practices, usually by hospitals or health systems, but increasingly also by private equity investors. So vertical consolidation, as we know, is increasing dramatically and has been increasing over recent years alongside all types of healthcare consolidation. And the pace of consolidation is accelerating. So for example, hospital acquisition of physician practices grew 128% between 2012 and 2018. And starting in 2012, only a quarter of physicians were employed by health systems. And by 2018, that number had nearly doubled. So according to the American Medical Association, for the first time ever in 2018, more physicians were employed than were owners of their own practices. And that is sort of a trend and a first that we saw in 2018. And it's not just hospitals acquiring physicians. Private equity-backed staffing firms have also been gobbling up physician practices, acquiring 355 physician practices between 2013 and 2016, for example. So these private equity investors are targeting specialties that have significant potential profits. So for example, emergency physicians and anesthesiologists are able to engage in out-of-network billing strategies, surprise medical billing, and balance billing because patients can't select these hospital-based providers. And so these are really good targets for private equity investors who can then sort of use these strategies to maximize revenues, of course, at the cost of patients and payers. So next slide. And so layered atop these existing trends, we see the COVID-19 pandemic is accelerating the pressure for vertical consolidation in healthcare. So whatever remaining independent physician practices there were, say at the beginning of this year, are suffering really significant financial strain due to COVID-19. And even those who previously might have resisted acquisition are now facing new pressure to sell to large healthcare systems or to sell to private equity investors in order to achieve financial stability and just survive and not have to shut their doors. So next slide. And of course, there's a mounting body of evidence that vertical healthcare consolidation leads to higher healthcare prices and spending. So when hospitals buy physician practices, hospital prices go up, the physician prices go up by a magnitude of 14% or more, and total spending per patient rises 10 to 20%. So it's not just independent, it's not just prices, but also total spending goes up. And so why is this? So of course, we've been hearing for years about all the promised benefits of vertical integration or just healthcare integration in general. But there are several ways in which physician practice acquisitions drive up costs. The first is the addition of facility fees. So facility fees are those fees that hospitals can charge for outpatient services provided by their acquired physicians. Even if nothing about that service has changed, now that it is a hospital, considered a hospital outpatient department, it's just the physician's office, the hospital is able to tack on facility fees on top of the professional fee that the physician normally would charge. And this additional revenue is a significant financial incentive in driving all of these acquisitions for hospitals. Of course, all of this revenue for hospitals comes at a cost to consumers and to patients and payers. The second thing that is driving up costs in vertical consolidation is that the consolidated entity, of course, is gaining market power as it gains in size. So it can leverage its market power to engage in all or nothing bargaining and insist on anti-competitive contract terms with health insurance plans. So just the same playbook that we see with horizontal healthcare consolidation, we see happening with vertical consolidation as well. And it allows this larger health system to demand higher prices for all of its providers, including its acquired physicians. Third, acquisitions allow hospital systems to direct the referrals of captive physician practices to a greater extent than they could for independent physicians, which increases referrals to higher cost and lower value providers and services. So it's both reducing choices for consumers, but it's also driving referrals to higher cost and lower value providers. And finally, private equity-backed staffing companies have used a strategy, as I mentioned, of going out of network, of targeting these lucrative types of practices, whether it's dermatology and gastroenterology, or whether it's these types of out-of-network providers, such as emergency physicians and anesthesiologists, to use surprise medical billing as a way to drive up revenue for themselves, but as a result, costs are increasing as well. So we are seeing this increased vertical consolidation in healthcare driving up costs, but it's also reducing consumer choices by creating these larger exclusive networks. And these higher costs and reductions in choice are not offset by any increases in efficiency or quality. So all of the promised benefits, we're not seeing that borne out. In fact, a lot of the most recent evidence is saying that there really is no association between increased integration and consolidation and quality. So it is no surprise, of course, that states are increasingly looking for ways to address the problem of vertical consolidation. All right, next slide. So why states? Why not, why is this a state problem? States are really in the driver's seat here. State oversight is critical because these vertical transactions tend to fly under the radar of federal antitrust authorities. And they tend to be too small in size to be reported under the Hart-Scott-Rodino Act. And so they generally occur without any oversight at all. So any one of these acquisitions may be too small for review, and so the federal government isn't reviewing them. And in many states, there is no review as well. So these health systems and private equity companies are incrementally growing their size and their market power, in many cases without any oversight at all. And the pressure for vertical consolidation created by this pandemic for physician practices who are fighting to survive means that in many cases, states may not be able to prevent this consolidation from occurring because these physician practices literally need to join a larger entity in order to survive. But in that case, states really have to think about policies to provide robust oversight over these consolidated entities in order to combat the risks posed by vertical consolidation. All right, so next slide. And so this brings us to the state policies. What can we do to address vertical consolidation? This table lists a range of policy tools states can deploy to monitor and oversee vertical healthcare consolidation. And again, we don't have time to go into detail about each of these today. We're going to focus on the ones that are highlighted for the most part and hear examples from Massachusetts, Connecticut, and Washington for specific examples, but I'll just summarize them quickly here, and they're of course provided in more detail in the policy paper as well. So the first is data gathering. At the end of the last session on healthcare cost growth benchmarks, David Selt said if he could ask for one thing, it would be data, right? Invest in data, and that's true for our policy recommendations here as well. One of the big tools a state can do to combat any healthcare cost increases, including that driven by vertical consolidation, is the use of an all-payer claims database or other sources of data in order to understand what's going on and be able to pinpoint the magnitude and the drivers of cost growth. So we're going to talk a little bit about that. And then we're going to look then at pre-transaction review and approval. And what does it take to provide some oversight before the transactions occur in order to prevent those anti-competitive transactions from occurring, or if they are subject to approval, to put conditions upon them to say, manage the anti-competitive effects of these transactions when they do go through. So we'll discuss what that process of review and approval looks like. And then once we have a already consolidated system for entities that have already had consolidation in the past, there are different regimes of oversight that a state can look to. And there are really three different bodies that we talk about as being able to provide oversight. And one is the Attorney General's office, particularly to police anti-competitive conduct by already large entities that wield significant market power. Another would be oversight by an independent health commission, like the Health Policy Commission in Massachusetts, but other states also have these independent health commissions. And then finally, we introduced the concept of using an existing state's certificate of need authority to be that agency that can sort of be repurposed to bring about some oversight, less on planning, although we still need a planning function, but more to be to have the capacity to provide oversight over these vertically consolidated entities. And then finally, again, once consolidation has already occurred, which is true in many areas, there also are strategies to control outpatient costs. So one that we're going to talk about in particular are restrictions on those facility fees that hospitals can charge for their outpatient services. And then we're also going to touch upon, but maybe not go into as much detail about what to do about private equity-backed consolidation and some other strategies for overall cost containment. So with that, I'll turn it over to our state leaders.
Thanks so much, Erin. This is incredibly helpful information for all of us, because as you know, it's sources like you that can do the research and lay the options out for us that are just so valuable. So let's go to the next slide. As Erin indicated, the first thing we wanted to chat a bit about is how states that do have APCDs are using data to help us sort of dig in on this issue of vertical consolidation, or even use it to look at different aspects that are related to vertical consolidation. So Vicki, can you talk to us a bit about how you've used that in Connecticut?
Sure, and good afternoon, everybody. It's very nice to be here today with my colleagues and all of you listening and watching today. The all-payer claims databases, I think, have not historically been seen as a tool for monitoring transactions, but they should be. They are a very powerful tool to monitor these transactions even before they happen. In our case, I have tried to make us start looking at what we're seeing in terms of costs and trends in healthcare prices across the healthcare spectrum with entities that exist as they are. And if we have a line of sight on a transaction we see coming, we can look at the APCD and see what kind of cost we're seeing at a baseline level. So if a transaction comes in and somebody's promising us that they're going to keep prices down, well, we're going to have an idea of whether that is really happening based on previous behavior with respect to prices where other transactions came into place. So let's say a large system has acquired 2 practices already. We can see pre and post transaction, because we have data back 8-9 years, what happened with respect to those prices pre and post transaction. And certainly if a transaction comes to our door, we will be looking at the current pricing structure for the entity as it exists. And then during the process, if they are approved, or even if there's discussion going on whether to approve them, we would condition their transaction on the ability to monitor their prices and restrict the level of price growth they could have. So the APCD is a powerful tool in that respect, because we can see all of their commercial data and their state employee data for every kind of inpatient and outpatient service. So that's one option.
Thanks so much, Vicki. And I think that concept that you referenced, the concept of the APCD providing a baseline level of information, is really critical. I know here in Washington State, we're using our APCD as a tool to implement our state's balance billing legislation. We were not able to get a benchmark rate to pay out-of-network providers. So there's an opportunity for the standard is payment of a commercially reasonable amount for the out-of-network services. And we have put together a data set from our APCD that shows median allowed amounts for in-network and out-of-network services that is being used both in negotiations between providers, but also for arbitration. But equally important, that data set is a baseline that we can use so that we can look at the APCD in future years to see what actual impact there has been on pricing as a result of the legislation. So having an APCD as a way to really see whether a policy that's been adopted has had the intended impact is really, really valuable. So how about the next slide? So we wanted to talk about now, as Erin indicated, pre-transaction review and approval. And so on that one, Michael, how about giving us some thoughts on the work with the AG's office and the Health Policy Commission? Michael, I think you might be muted.
Classic. Thank you. Sorry. Yes. That's good, because the first thing I need to say is that as an employee of the Massachusetts Attorney General's office, I'm speaking on behalf of myself and my own personal opinions. What I say today does not reflect necessarily the policies or positions of the office. So being on mute reminded me that I needed to give that disclaimer. So in Massachusetts, we are fortunate that we have the Health Policy Commission that gets notification from providers when they undertake certain transactions, if it is over a certain threshold in terms of the revenue of those providers. And that applies to horizontal and vertical transactions. So as was pointed out, sometimes these transactions can be small and don't rise to the level of Hart-Scott-Rodino filings with the federal authorities. But fortunately, in Massachusetts, we're getting notice of those, and there's sort of a mandatory waiting period before they can close, where the HPC has a window to review whether they're going to undertake a review. And that gives us also our opportunity to undertake our sort of separate parallel review under the antitrust laws and other authorities that the Mass AG's office has. The HPC has what they call the notification as material change notice, and then they can decide whether they're going to undertake a cost and market impact review that has a pretty wide view on what the transaction might do to the market, not only in terms of price and competition, but also in terms of access, affordability, other sort of things that may not come under the purview of an antitrust review. So we have sort of this parallel process. At the end of the HPC's process, they can refer the transaction to us if it meets certain statutory requirements. That doesn't necessarily give us more authority, but it is a helpful tool in terms of notification of when a transaction has an issue.
Great, thank you. And Vicki, you talked about how you use the APCD when you're looking at pre-transaction reviews. So how does that work in Connecticut?
Well, we have a similar, we pretty much copied Massachusetts in terms of the notice of the transaction. So the Attorney General's office here also gets a notice of proposed transaction, and group practices up to or above 8 providers, regardless of whether it's horizontal or vertical, are subject to certificate of need approval in our state. But they're also potentially subject to cost and market impact reviews. As Michael said, Massachusetts does. Same thing here, although OHS does it here, the Office of Health Strategy. Unlike, we don't have the HPC, but we have the Office of Health Strategy in Connecticut. So we take a look at them. I will say, I think it's a limited review. The CON has more potential, at least the way the current law is structured, I think, to make an impact with respect to these transactions. And I think Erin referred to this when she first started her presentation, but I think some of the limitations on this are transaction by transaction review, rather than a whole system look at the transactions in total. So for instance, one acquisition by one hospital, for instance, of one group practice may not be a big deal, but if they've done 10 of them in a row, it could be a very big deal. So I think that's a limitation of the current law. And we do have notices of material change. Same thing, they come through our office and the Attorney General's office. We use one form, so both offices can get notified at the same time.
And just a quick follow-up question for both of you on this issue of transaction by transaction by transaction. When a new notice comes in of a planned transaction, are you in Massachusetts and or Connecticut able to look back at what has been approved and look and have that in any way, means, shape, or form influence how you're looking at a new notice that's come in? Either of you?
Sure. I think, as Vicki mentioned, I think anytime we're undertaking antitrust review of a transaction, there's sort of that serial question. Is this a number of serial acquisitions that maybe one of those transactions doesn't necessarily cause a accumulation of market power that would be concerning, but over the course of time, there would be a concern when they're all added together. So there's definitely always a backward looking and a forward looking view of, well, what is the market developing into? And that definitely impacts how we review each transaction.
And Vicki?
So we have a similar thing. We can look forward and back. And in our state, same sort of thing. The AG's office pretty much takes the lead, obviously, on the competitiveness and the antitrust implications. But we also have filing requirements for all these practices. So over time, we know exactly who is where, which group practices are situated where, who owns them. They're all on file with our office, what kind of specialties. So anytime somebody's coming in for another transaction, we can look back at all of these filings and see what the environment looks like to see if we think there's going to be a problem. And if there is, we can undertake the cost and market impact review, but we can also refer over to the AG's office.
That's great. And in Washington State, we are just getting started. A new state law passed in 2019 that requires advance notice of a proposed merger, acquisition, or contract affiliation, again, both horizontal and vertical. And the statute was intended to sort of gap fill in that we capture transactions that are not reportable under Hart-Scott-Rodino. And also we have reporting of, for example, contract affiliations, which are not required under Hart-Scott-Rodino. And to date, as of June 26th, we've received 15 notices of material change. So definitely see things going on in the market, no question about it. So I think have Michael or Vicki, do you have any other comments with respect to prior review or approval or conditions that you're able to match, or should we march on?
I think we're good to move on my view. Yeah.
Okie doke.
Same here.
Okay, next slide, please. So moving on to Attorney General enforcement against anti-competitive conduct. Michael, I think this is your bailiwick.
Sure. So I think from a wide lens of the antitrust laws, antitrust is sort of having a moment right now in terms of looking back at what the goal of the antitrust law should be. If you've heard of Brandeisian or new Brandeisian viewpoints on antitrust, there's a question about whether organizations are just too big, regardless of whether under sort of the consumer welfare standard that has been predominant in antitrust review for the past 30, 40 years, whether we should take a wider view. And Tim Wu's book on this and many other scholars are sort of having this conversation, especially with respect to the tech companies. But it definitely has a wider impact on what we're looking at, including in healthcare. Vertical mergers are also getting more attention. New vertical guidelines were finalized by the DOJ and FTC just on June 30th of this year. So there's a lot more focus in these areas and looking at not just those horizontal mergers, but other kinds of transactions that might accrue market power at a level and what impact that might be having on the operations of our markets. One of the difficulties in looking at vertical mergers is that they haven't been challenged very much. The federal authorities haven't really brought a vertical case in the past 20 to 30 years, other than the very recent Time Warner AT&T transaction, which does give some viewpoint in terms of how things might be changing. But it's also important to note that the federal government lost that case pretty badly. And, the theory, I think, is solid, and they weren't able to prove it there, which is that Time Warner content, HBO, other Warner Brothers, they would be able to withhold that from other cable providers that it competed with and recoup those losses when subscribers would leave, say, Comcast to come to AT&T because they couldn't get HBO. I think the difficulty in transporting those theories to healthcare is it doesn't really address what Aaron's paper talks about, which is sort of that increased bargaining leverage when sitting across the table from a payer. A lot of the vertical theories, and if you review the updated vertical guidelines, look at how your acquisition of those physicians would be impacting other hospital providers. And, are you cutting off their ability to compete in the market against you as a hospital? And that's not necessarily the problem that you see in the markets that we're looking at. And there's also not sort of a solid track record of case law that you can point to and say, well, here's the theory as to why this acquisition of physicians is harmful. The cases that have sort of come up, the St. Luke's case in Idaho was ultimately decided on horizontal grounds. And there's a lot of the Sanford Health case, which was looking at Sanford Health, which had an insurance arm acquiring some physicians and looking at the impact that would have. And I think the most important, and this is also not touched on in the paper, but looking at insurers acquiring physicians, which is sort of a third door beyond the large health systems and private equity. And sort of the most recent and most in-depth look at sort of one of these vertical transactions was Optum, United sort of physician arm acquiring practices in Colorado, Nevada, and a few other states. And the FTC had some divestitures in Las Vegas, but otherwise said that the evidence of vertical harm, or at least the Republican majority said the evidence of vertical harm was not compelling. And they said that it was at least ambiguous, and therefore this was not the case they wanted to roll the dice on. But looking at what states can do and states' sort of wider viewpoint in terms of policy, the Colorado AG's office took independent action to end an exclusive contract that United had with one physician group and to extend the contract that Vida had with Humana, because they were concerned that United would cut off access to this physician group and therefore, again, sort of like that AT&T Time Warner transaction, be able to recoup those losses when people said, well, I want to see my doctor, I'm going to switch to United. So it shows again that we as states might have other solutions or possibilities that we can put in place that maybe the federal government won't use when we see these sorts of transactions.
Great overview of the issues. Washington State's recent experience with this was the CHI Franciscan litigation. And that was also, Michael, as you indicated, that was a horizontal integration case involving a hospital system acquiring physician practices, both primary care and orthopedics. And as Erin mentioned in her paper, that case was settled. And when you talked, Michael, about there not being a whole lot of case law out there, when you think about, I'm sure you know this super well, how resource intensive it is to litigate these cases. I mean, our AG's office determined that a settlement was the best route to go, and there were some significant things that were achieved as a result of that settlement. But you're right, it doesn't give you case law. So, Vicki, any thoughts on the antitrust litigation issue that you want to offer?
I'm not an antitrust lawyer and don't even pretend to play one at conferences, but we generally look to our AG's office. If we do suspect there's an issue, we will refer it. We will refer it over. We know enough to do that. And we have a good antitrust team over at the AG's office who is very active.
That's great. And so I think with that, with Michael's statement about are there other things that states can do? Do we have other tools in our toolbox? Vicki, I want to throw it over to you because Connecticut is such an example, a good example of a state that has really used its certificate of need authority in creative ways on this issue.
Oh, thank you. I think we have a couple slides we'd like to share with the folks here today. We have, since the Office of Health Strategy was created in 2018, we've sort of taken a different look at CON, a broader look, put a broader lens on it, on market impacts, how it affects access, prices, et cetera. So CON, what you're going to see in a couple of these slides may be a little broader than vertical consolidation, but does come into play, particularly with respect to hospitals that are acquiring physician practices. So since OHS began, we have started inserting cost caps, and we thank Massachusetts again. Thank you, Michael, for its leadership with respect to the partners acquisition. I think that was a year or so ago. He can correct me. In which cost caps were included, cost caps on unit price increases in the transactions. We have done that as well. We have not, like Erin said, seen evidence that prices have gone down in these sorts of transactions. In fact, they've gone up. And we want to make sure those prices are controlled at a reasonable level. So we have included cost caps in these transactions. Often when a transaction comes in, let's say a hospital merger or acquisition, the group practices come as part of that. And so we have extended the cost caps to the group practices when such a transaction has happened. That, in addition to additional conditions we've placed on the transactions. Again, we have included conditions that require APCD to be used. The All Payer Claims Database has been administratively noticed in our decisions as being used for monitoring these transactions with respect to price and utilization. So we can ensure we're not seeing increases in certain pockets of utilizations to make up for, let's say, price caps that have been put into place. We've also extended conditions beyond the normal period. As you know, certificate of need is transaction related. So you're not controlling the entire marketplace, but you're controlling a particular transaction. 3 years is the default, or 2 years in some cases, the default oversight of a transaction. That's just not enough time to see what the impact of any kind of acquisition would be. So we've extended them up to 5 years in some cases. And something you might not think is much related to this issue, but we have required, if you're going to, that in these transactions, if there's going to be an acquisition, there better be better community benefit alignment with the community health needs assessments. In other words, if you're going to invest dollars or there are extra dollars to spend, we'd like you to invest them in the community in which you're residing. With respect to physician groups, as I alluded to earlier, we only have oversight for group practice acquisitions larger than 8 physicians. You know, I get it in some ways, right? This was a political compromise. It really was a political compromise. And like everything related to CON, it is subject to politics of the day and legislative negotiation. But 8 physicians can be, in Connecticut, in an environment where there are a lot of onesie twosies practices. 8 doesn't seem like a lot, but it's a lot. So I would like to see that number lowered, quite honestly, because eight physicians is only going to get us a certain level of review. The other thing I alluded to earlier is material change notices come to us. So next slide, please. So what are the challenges, right? So CON is a good lever, but it's a limited lever. So again, it's only tied to a specific transaction in front of you. So I can only review under the Administrative Procedures Act the actual application that is in front of me. So that makes a big difference in terms of reviews. The market in Connecticut, like in many places, is already very highly concentrated. So that makes decision making in some cases easier and in some cases harder. But in the case of the physician group acquisitions, whether they're horizontal or vertical, they're deemed approved in our law. That means they're presumptively approved under the law. That means you have to overcome, the office does, upon a review. The evidence has to overcome the presumption that the transaction is approved. So that's a much higher burden. In regular certificate of need transactions, they are presumed to be denied unless the applicant can overcome, the presumption of denial. And that's where I think a burden shift would be ideal in this kind of case, but deemed approved makes it very difficult to reject one. And that's in part simply because of volume coming in the door and the ability, resources in the office, the volume coming through the door, and the ability to collect the kind of information you need to overcome, the application being deemed approved. We also don't have oversight of private equity, which is something Aaron referred to earlier, which I think is a big issue that needs to be addressed. Again, COVID, as was discussed earlier, that has accelerated or has the potential for accelerating primary care acquisitions in particular, maybe other specialties, but in particular primary care. I have very major concerns about that because Connecticut is a state that's had a lot of independent practitioners that have been competitors for some of the larger systems. And it makes me a little nervous that we could lose some of them because of COVID, which raises other issues that were addressed in the previous session. Again, the oversight is a short period. You need a long time to look at these transactions to see what the real outcome is. You're not going to see it in 1 year, 2 years. You need a little more time. We don't have the ability to oversee capital. So if practices are acquiring each other, but also making significant expenditures by building out buildings and like having a baby gap on every corner, as I analogize to for when I lived in New York City, that's a problem because you can't oversee those kinds of transactions. And the thing that we're seeing a little bit of a trend in is, even though there are concerns about that vertical integration, there are some entities that are trying to move away from primary care. And that makes me a little nervous for overall cost containment and improving care delivery and improving primary care. So some of those larger hospitals that may move away from primary care may lose some incentive to be involved in some of these alternative payment models that could conceivably bring down costs and improve care quality. So those are some of the challenges that we see with the current law, even though I would rather have it than not have it. And the other thing I would add, because I saw a little question in there from Elena Nicololo. Hi, Elena. The New England states have been working together about ways to oversee the market. Michael's team has been a part of that as well, the AG's office in Massachusetts and the HPC in Massachusetts, as well as the other states. And one of the things we've looked at and Connecticut has done is really engaged in a data sharing agreement with Massachusetts around transactions that are cross-border. And we think that has the potential to really influence behavior in the marketplace by knowing that Connecticut can come in on a Massachusetts acquisition that affects Connecticut or vice versa may be helpful to overall market review over time. So just some of my thoughts.
Yeah, Michael, any thoughts on the response to the question about the regional effort?
Yeah, I think there's definitely a lot of transactions now that are crossing borders. We have our Partners Healthcare, or Mass General Brigham, as they've rebranded, that is spreading out in different parts of New England, and definitely cooperation about helping states review those transactions is important. But ultimately, from a AGO perspective, if there's a transaction that involves providers out of state, they have jurisdiction over that, and likely are the ones that would bring a claim. So there's definitely cooperation, and you want to be able to share information to the extent that you can within your confidentiality provisions. But ultimately, each jurisdiction does have its sovereignty and ability to make an ultimate enforcement decision. And as Vicki said, they're under their CON, something is deemed approved. In Massachusetts, it really falls to the AGO to bring a transaction or bring a lawsuit to stop a transaction. There is a determination of need process that has some similarities to what Vicki described, although not my specialty, so I don't want to opine too much on it. But we have to bring an affirmative lawsuit to stop a transaction. We don't have approval power or not. So there's a high burden on us to bring an action to stop something.
Okay, thanks so much. We also had a question from Cindy Watts about whether there have been any evaluations in either Connecticut or Massachusetts. I know in Massachusetts, the HSC has its annual report that or the HBC has, that shows its sort of annual report of cost trends over time. And so either of you, before we jump into facility fees, have there been any evaluations that you're aware of looking at the impact of your actions? They haven't been in effect super long.
No, not in Connecticut, not with respect to OHS, not yet. The transactions all require independent monitors and reports over time of the impact of the transactions. However, I mean, regardless of that, I still think we have to look back and see whether we were effective or not and how to make changes or improve on the process. But I want to say too early in some of the transactions we approved, but we welcome that.
And that does go to the importance of the APCD and using it to measure. Michael, any thoughts, other than the annual reports that are put out, any other evaluations?
Sure, I'll echo what Vicki said in terms of the Beth Israel Leahy transaction, which I think Vicki was referencing with respect to the price caps. There are other conduct remedies that were agreed to in that assurance of discontinuance, many of which don't involve competition but involve access and other things. And there is, as Vicki said, there's an independent monitor that does an annual report to make sure that there's compliance with those terms in the agreement. Our healthcare division also does an annual report, not with respect to transactions, but with respect to where the market is, cost growth, access, and other things, similar to what the HPC does, although looking at different aspects.
And Jane, I guess I would throw into that, and thank you, Michael, for the correction.
So everything is partners up here, so I'm fair.
That what Aaron referred to early on was the lack of improvement in quality. And I think quality sometimes gets a second chair with respect to a lot of these transactions. And it has historically been more difficult, I think, to monitor quality over time or decide on measures of quality that you'd want to use for some of these transactions. I think that's a fruitful area for further exploration for NASHP and groups like that to look at what are the key kind of quality measures you'd be looking at in these kinds of transactions, particularly whether it's primary care or specialty care. We know that there are thousands of quality measures, but what are the right ones to really be looking at?
Right, and where does quality come in? I know it was discussed during the total cost of care session, but you think about quality in the context of cost benchmarking and cost trend benchmarking. Yep. Okay, so can we go to the next slide? And we are going to finish up chatting a bit about facility fee restrictions, and then just to see if anybody has any comments about counteracting private equity-backed consolidation. And then hopefully we'll still have a few minutes and to answer a couple of other questions that are still in the queue. So Vicki, why don't you talk to us about facility fees in Connecticut?
Yeah, I'll go. I will hope to go very quickly. Just cut me off. But facility fee is one of the things that I find the most frustrating in the entire market are facility fees. We've done a lot of work in Connecticut over the years that led to an actual ban on evaluation and management codes, or facility fees being allowed for evaluation and management codes. That again was a compromise, but a pretty good one at the time, since we had no bans on facility fees otherwise. And we were seeing extraordinary facility fees, and facility fees that had no rhyme or reason and were kind of impossible to break down and get to the actual facility fee for. So you might have a $2,000 facility fee in one place and $1,000 in another place and $100 in another place. But getting the ban was good. One of the challenges with it is it's only for off-campus hospital locations. So that means if the hospital has some on-campus locations, we can't reach them right now under the law. However, we did include notice requirements in the facility fee transaction. So anytime a hospital or anybody was going to impose a facility fee, they had to issue a notice to the consumer prior to the visit, giving them an estimate of the fees and also comparing them to the Medicare, what Medicare would charge, and allowing them obviously to choose a different provider. And a private right of action was also created in the facility fee bills. So there is a presumption of the violation of unfair trade practices if these facility fee requirements are not met. So we have done some significant work in the area. However, many of the hospitals have switched to A&M codes instead of E&M codes, which are not covered by our existing law. So we have proposed a new bill to try to reach those fees. There is widespread use of facility fees still in Connecticut. We report on them annually. They're in the hundreds of millions of dollars. Some of our hospitals have said without them, they would go under. That may be true for some of the little ones looking at their financials. However, I don't think it's true of the big systems, but there is widespread prolific use of them. I think facility fees are still a little bit opaque, despite the legislation. So we proposed a new bill to be more specific in terms of the requirements with respect to the systems. And the notice requirements that we put in are really not that easy to enforce, because you have to, how do you look at every single notice? You have to look at model notices and hope that they are good notices. And facility fees, one of the main remaining challenges for us is extracting the data from the all-payer claims database on the facility fees. They are not coded necessarily like you would think they'd be coded for a claim. So they're not easy to pull out of the data in the APCD. If they were, I think we'd have a better shot of probably limiting them even more than we have. So I do think there's a lever there, though, for other states, and they are significant in terms of the costs and the impact on consumers. Consumers are often blindsided by them, and I think it would be great if other states got into this area or even had some suggestions for us to improve our bill or our legislation.
Thanks. That's really helpful. So let's finish up on the question of private equity-backed consolidation. And Michael, I'll look to you for some comments, and then Erin also, if you have any comments, and Vicki, and then we can try to get to a couple of questions that we still have out there. So Michael, your thoughts.
Sure. I think that this raises an interesting question, sort of puts the broader lens that affects these transactions in focus with respect to antitrust. Looking at the three options, if you have a physician group coming to you and saying, we're not going to financially make it unless we're bought by somebody, and their options are a private equity firm, a large healthcare system, or an insurance provider. The least competitive may very well be a private equity, or the least anti-competitive from the perspective of competition in the market may very well be a private equity firm, because unless they own a lot of other physician groups in the market, they don't have any existing competitive relationships there. So they're sort of from the view of the antitrust laws, assuming they're not consolidating a bunch of physicians, they are greenfield expansion. They are keeping that practice more or less independent from other vertical players in the market. But clearly there are other healthcare policy views that would frown upon what we've seen happen when private equity firms acquire healthcare providers. So the difficulty is, I think, for a lot of states, the main enforcement hammer they have when a transaction occurs is looking at it through the view of antitrust, and then trying to accomplish other policy goals through that enforcement hammer can be difficult and sometimes contradictory. So, from our standpoint, from a purely antitrust viewpoint, the private equity acquisition probably doesn't raise a lot of questions in most instances, but from a health policy standpoint, it may raise much more serious questions, and you might be faced with deciding, well, what's the least bad option if a practice is truly failing, and competition in a lot of instances may not be the right lens to look at something like this.
Point well taken and very interesting. Erin, any thoughts you would want to offer on that?
So this phenomenon of non-healthcare companies investing in healthcare services is raising a lot of eyebrows in terms of policy. So there are a couple of direct sort of practical things a state can do. One, the first, of course, is just to gather the data. So again, I don't know if APCDs right now have any way of tracking from the NPI code who's actually owned by a private equity company, but that would be something that would be worth figuring out if you can track. Same, to Vicky's point about the facility fees, if you can put a number on it, then you can see what's going on and we can actually tell whether this is a problem and to what degree. The second thing about this is to look at, as I mentioned early on, one of the strategies that private equity investment in healthcare has had is to use an out-of-network revenue strategy. And so one of the immediate policy recommendations is for any state that hasn't already passed comprehensive surprise medical billing legislation, that would be one thing to do, right? Because if one of the ways private equity companies drive up costs is through out-of-network, making their physicians go out of network as a general matter, and then balance billing, and then demanding charges from health plans. I think that would be one way to kind of get at those excess costs that are just a source of revenue, frankly, for the private equity companies. Another thing to look at, and this is something that's sort of nascent in the sense that I haven't studied it, I don't know of any empirical sort of, again, data on whether or not this is true, but it's worth thinking about whether to revive the good old corporate practice of medicine doctrine. So some states have a really strong corporate practice prohibition still to this day. Other states, it's sort of on the books, but not really enforced. But this is exactly the kind of corporate practice of medicine that the doctrine was designed to counteract. Not necessarily the hospital acquisition of physicians, but the sort of lay corporate control of, by profit-holding, profit-seeking entities in healthcare, and the running of physician practices through a profit model instead of a physician sort of medical model. And so I think that is something worth studying and something I'm interested in looking at. And it would be interesting to see if there are any states who feel like they have had some experience with the use of the corporate practice doctrine, the licensure and the corporate practice doctrine in their state to push back on some of the entry of private equity into their market.
Excellent thoughts. I can say that in Washington State, we do have comprehensive balance billing legislation, as I had mentioned, mm-hmm. and we have had between 50 and 60 requests for arbitration filed to date, and virtually all of them have been either emergency physicians or anesthesiology groups. We don't know which of those may or may not be backed by private equity, but it does seem to follow a pattern that we've seen in other states. Mm-hmm. So let's see, we have a few questions. Let's see if we can take them. One, Vicky, this is a super easy one. The definition between E&M and A&M.
I think it is. For the longest time, I could not figure what these are. But Medicare had expanded the coding for things that used to be called E&M to A&M, which I think is ambulatory, but I could be wrong about the A. It's a broader set of codes that of which E&M, evaluation and management, is a subset. But it's just a broader set of codes that facility fees have been attached to quite broadly. So that's sort of the answer on that one, but I should verify whether it's ambulatory, to be fair to the audience. But I do know it's a blowout of the E&M. It's just a broader set.
Okay, that's helpful. So that would have been, did it show up in the ICD-10 maybe? In the update to the ICD-9?
Yes.
Okay.
ICD-10.
Okay.
And then Medicare responded to that by adding them to their coding, to their list of codes for Medicare reimbursement.
And so we had a question, speaking of Medicare, since Medicare has site neutral payment on facility fees. Any thoughts on service versus site in terms of facility fee restrictions? And either Erin or Vicky, any thoughts on that?
Yeah, I can take this and see if Vicky has further thoughts. So one of the things is there's somewhat of a nomenclature issue of, sort of a prohibition on facility fees, which target providers typically. So the way that the regulation of the legislation is structured is that hospitals may not charge facility fees is usually how it's worded. Whereas site neutral payment is talking more from a payer perspective. So usually it would be an insurance regulation matter. And when we see the innovation coming from Medicare, it's a payer, right? And so the Medicare system has put into place site neutral payment in, starting in 2000 for transactions that occurred after 2015, and then have been expanding that effort in litigation, et cetera, beyond those types of efforts. And so site neutral payment of facility fees are really targeting the exact same phenomenon, which is that we shouldn't be paying more for the exact same service just based on the fact that it's classified as a hospital outpatient department, even though it's just a physician's office. And so it's the same concept. It's just for a state to think about where to place that regulation. Of course, states have more leeway over providers, and it would have a broader effect to structure your facility fee regulation as a prohibition on providers or a limitation on providers, as opposed to, although you could, structured as an insurance regulation and to force as a sort of condition of insurance licensure or to get your premiums approved, your contracts approved in a given year, to require site neutral payment of your insurers, your licensees. Of course, that only applies to that limited, fully insured private insurance market that the insurance department oversees. It wouldn't reach the self-funded employer-based plans and other types of payers that aren't subject to insurance regulation. But we know that Rhode Island, for example, has done that through regulation. And so it is a sort of an alternative pathway. We just think that the broader idea would be to implement a broad facility fee prohibition. And just to kind of put an example out there, it's in the paper, but Massachusetts, the Governor Baker had proposed a broad facility fee prohibition, even broader than Connecticut's, in proposed legislation in the fall of last year. It didn't pass, but it is there, and it provides sort of an example of sort of a site-based facility fee and is also a service-based. So all E&M codes, no matter where they are, but also sites. So off-campus services provided more than 250 yards from the main campus cannot be cannot be charged a facility fee. So that those two approaches are actually, we see some legislative examples, although none have passed just yet.
Okay, well, I think we are just about out of time. The last question related to, have we seen any changes in private health insurance related to vertical consolidation, for example, network breadth and/or premium costs? I'm hoping, Erin, that some of the sources that you had in your paper to show what's happened with trends as a result of vertical consolidation can help the person who asked this question and others as well.
Yes,
and so with that,
I'll follow
ahead.
up with them later. Yeah, no, I think that there is evidence. I don't know the study offhand, but there is evidence that premium costs do go up with vertical consolidation. So it drives up costs.
Good information for everybody. So thanks so much to Vicki and Michael and Erin for your great contributions. Thanks for the great questions. And as always, I have to remind everybody to please fill out the evaluation. Thanks so much for your interest. And with that, I think we're done. Take care, everybody. Be safe.
Thank you.